It looks like a cast, and it is, and we're asked what it is. And we're offered 3 blood vessels and 2 bronchial trees, left and right. We would think that unless someone has made a cast of blood vessels post-mortem to show some sort of an anatomic anomaly, that this would not be a blood vessel, since after death occurs, the thrombosed vessels, the thrombi get smaller and don't show a delineation as is shown here. Besides, this doesn't look like the portal vein, the femoral vein, or the hepatic artery. So we're left with right bronchial tree or left bronchial tree. And unless the examiners were nasty enough to turn the thing over on its back, we would have to guess right bronchial tree. And indeed, that is the correct answer. This is a right bronchial tree. Patient with severe heart failure who has a left ventricular assist device develops hemoptysis and worsening shortness of breath, and has an extreme coughing episode and coughs out this huge cast, which undoubtedly consists of thrombus and cellular debris to make this structure. As I learned this week, shortly thereafter, the patient died. And this would be the anatomic replicate indicating right main stem bronchus, upper lobe, middle lobe, lower lobe, as shown here, corresponding pretty well to the picture that we saw. The first topic in the New England Journal is peanut allergy. That's the most important food allergy in the world. It can be incredibly dangerous, and young people can develop anaphylactic shock and die within minutes. And the daughter of a close friend of mine and associate about 15 years ago died because she ate some candy that had hidden peanut that she couldn't identify by glancing at the label. If she bothered to read it, I'm not certain. But in many food products, it's not clear that peanut is present inside the products. So children with peanut allergy, if it's severe, are outfitted with syringes of adrenaline so that they can treat themselves to avoid dying of anaphylactic shock. Now, this is a problem, and it's related to the fact that the people that are allergic have an increase in IgE immunoglobulin, which is deposited in tissues on mast cells. And when they're exposed to the peanut antigen, this IgE activates these mast cells that then release all the materials that result in anaphylactic shock. Desensitization strategies have been around for 100 years. But in this case, it concerns with oral desensitization by increasing level of peanut exposure to these young people with peanut allergy in the hope that they're able to put away more peanut material before developing symptoms so that they at least don't develop anaphylactic shock. We've discussed this idea in the past, and there have been excellent papers about this. And this is a randomized controlled trial of AR101, which is a peanut product, compared to placebo in patients with peanut allergy. And peanut allergy was established by history, by exposure to peanut, to see if they got cutaneous or other symptoms, and the determination of IgE against peanut. So 372 people in the peanut group, AR101, and 124 in placebo. And the endpoint here is how good are you at putting away peanut product before you develop symptoms? So we'll have a look at that. And what we see here, AR101, some of these patients, this would be 1,000 milligrams of peanut product. And half the patients in this column were able to put away that, compared to a very, very small number in the placebo group. And this group of patients at least were able to put away 600 milligrams of peanut or 300 milligrams of peanut. That would be enough to avoid anaphylactic shock or any sort of dangerous happenstance. And these were the youngsters that were under the age of 17. In patients that are above the age of 17, there was no positive effect. So this therapy is for children to try to outfit them so that they at least do not die when exposed to peanut. Here are symptoms that the events that people get that are allergic to peanut, and if this can be diminished, you can look at this table at your leisure by ingesting AR101. That would be the hope here. So in this phase 3 trial of peanut oral immunotherapy, the patients aged 4 to 17 years of age showed a positive result that they could be desensitized to a large degree, whereas older individuals older than 17 were not helped by this therapy. The next topic is probiotics. And probiotics are the therapeutic hope that if we feed people good bacteria, like those wonderful lactobacilli, that we can treat conditions that come about through bad bacteria, like Clostridium difficile, for instance. And that would be an example where this idea has pretty good evidence that it might work. But there are products available and even approved for marketing in Germany, where the idea is to feed young children with diarrhea and acute gastrointestinal symptoms a probiotic in the hope that it makes their condition go away more quickly than doing nothing. And everybody believes this. So randomized trials were done to test this notion. And in this first study, children with severe gastroenteritis, bad enough to bring them to an emergency room, were evaluated by physicians. Their severity was judged on the basis of the Efficacy scale, as shown here: duration of diarrhea, number of watery stools, how many times they vomited, vomiting episodes within 24 hours, rectal temperature, emergency room visits, etc. And you can't see this table, but basically the children that got placebo in comparison to the children that got the great lactobacilli, they were similar in terms of characteristics. Diagnoses were made, stool samples were collected, and in about half the patients, an etiology could be determined, and half of those diagnoses were viral causes, rotavirus, norovirus, some adenoviruses, etc., enteroviruses, and some bacterial etiologies were found. But what we can see here is that the placebo group in blue and the probiotic group in red recovered at exactly the same rate over time, and their vomiting episodes disappeared similarly. This result implies that the probiotics did not improve the course of this condition. Now, just to make sure, the study was repeated in a second study, same design, same Lactobacillus rhamnosus was given compared to placebo, and the same Efficacy scale was used to judge the infants. And here they are, again, the diagnoses: norovirus, rotavirus, some bacteria, and in about half the kiddies they couldn't figure out exactly what the cause was. But again, the same result: probiotic and placebo, same recovery of diarrhea and same recovery of vomiting over time. These results suggest that probiotics, at least involving Lactobacillus rhamnosus, are of no value in childhood gastroenteritis with nausea, vomiting, and diarrhea. The next topic in the New England Journal has to do with the anaplastic lymphoma kinase, abbreviated ALK. ALK was discovered in lymphomas, but exactly what the role of ALK is still not clear. But we've learned that ALK is commonly involved in patients with non-small cell lung cancer, and the involvement generally involves a translocation with another protein, the echinoderm microtubule associated protein like 4. And Translocation and placing these two items adjacent to one another results in ALK activation and probably plays a pathogenetic role in non-small cell lung cancer, at least in the ones that have a mutation in ALK. So to block ALK, we've got a drug called crizotinib, and it's quite effective, but it doesn't penetrate the central nervous system very well. And brigatinib is a second generation tyrosine kinase ALK inhibitor that might be better. So in these patients with non-small cell lung cancer that had an ALK mutation, whether or not they had brain metastases, and that was one of the endpoints here, were randomized to brigatinib or crizotinib. And what we see here in these waterfall diagrams, both drugs lead to a partial response of tumor, but only brigatinib is a hero in terms of progression-free survival, which is substantially better than crizotinib, largely because these brain metastases did a lot better with brigatinib compared to crizotinib, or the development of brain metastases was also inhibited, as shown here. So brigatinib beats crizotinib, and you can look at these odds ratios, especially in terms of central nervous system happenings, as indicated in the lower portion of this table. And brigatinib has adverse events, especially increasing creatine kinase levels, although I didn't get the impression that myopathy was a major problem here. But it looks like we have something better to offer patients with non-small cell lung cancer if they have an ALK mutation. And of course, these tumors should be evaluated whether or not ALK mutations are present. So brigatinib beats crizotinib in patients with non-small cell lung cancer and who had previously not received an ALK inhibitor. The review in the New England Journal involves PI3 kinase, which is the phosphinoinositide 3,4,5 trisphosphate. It's a kinase that phosphorylates PIP2 to make phosphatidylinositol 3,4,5 trisphosphate, which then signals further to activate ACT and to throw on the entire mTOR pathway that results in less cell death and more cell proliferation. Now, PI3 kinase is activated through tyrosine kinase receptors, and those are many growth factors, but also insulin and insulin-like growth factor signal over receptor tyrosine kinases that turn on PI3 kinase. And PI3 kinase is a membrane-bound kinase, and a lot of these signaling pathways involve membrane-bound components. So PI3 kinase is pivotal to this kind of signaling pathway. And it's bound to membrane as this phosphatidylinositol group here. Here's diacylglycerol also involved in signaling. Here's the kinase, the inositol head and the kinase head to phosphorylate PIP2 to make PIP3. And this material was discovered in the framework of the discovery of the Rouse sarcoma oncovirus and other oncogenes. And so PI3 kinase family is basically also an oncogene. And what we can see here is that PI3 kinase is involved in a whole row of cancers for which we have rather poor treatments, such as endometrial cancer. We do somewhat better with breast cancer, although there's lots of room for improvement. All the green areas shows the mutations that PI3 kinase plays in these individual cancers. And PI3 kinase is also involved in energy metabolism and growth and liver disease and all sorts of things, because it also signals insulin receptor and insulin-like growth factor, etc. And these things are shown here. P10 is a tumor suppressor, as the phosphatase of the tensin homolog, human tensin homolog, and it inhibits the signaling through PI3 kinase. And the role that this plays in hepatic metabolism, glycogen storage, and also if we inhibit PI3 kinase, we can expect hyperglycemia, and we might be able to deal with that with ketogenic diets or SGLT2 inhibitors. If we're ever going to develop this treatment to treat patients with malignant tumors, and that's the profound hope of the author, Dr. Cantley, who also has lectured at the MDC. So PI3 kinase is a key regulatory node in growth factor signaling across evolution, and it looks like it ought to become a reasonable cancer therapy target and also amenable to the treatment of metabolic conditions, or so we hope. Now, the patient this week in the New England Journal is a 29-year-old man who notices a lump in his left testicle. He goes to the doctor, who determines that he has a left-sided varicocele. Routine work is done, including imaging, very important because all this laboratory data that I show you on this table is all normal. But the imaging shows a large right renal mass that obviously can't have anything to do with this left varicocele. And this right renal mass is very impressive on CT, and it has some cystic areas here, and the vena cava is pushed to the left side, and we're asked what this possibly could be. The discussant mentions the fact that a varicocele on the left doesn't fit with the tumor on the right. Could this be a benign tumor? And the commonest benign tumor that this might be is oncocytoma, but they're not that common, but they can mimic renal cancer. Could this be an inflammatory mass? Well, we have no signs of an inflammatory disease, but xanthogranulomatous pyelonephritis is in the differential, but we're stuck with renal cancer. And imaging has led to a completely different methodology in diagnosing renal cancer, because these tumors are picked up as incidentalomas, which helps a lot of people because then treatment can be applied long before symptoms develop. Could this be part of a systemic syndrome like the Birdhog-Dubé syndrome, which involves cutaneous manifestations? Doesn't look too likely in this case. Could this tumor be driven by somatic mutations? And that's certainly possible. The microphthalmia-associated transcription factor family could be involved here, and indeed TFEB mutations are common and are not uncommon in younger people that have renal cell carcinoma, and the interactions between this transcription factor and ACT signaling and mTOR signaling is given, consistent with everolimus and sirolimus treatment in patients with renal cell carcinoma. And so this patient needs a nephrectomy, and he got one, and indeed he has a TFEB translocation. Then the authors draw attention to the fact that we have to look to see if there's a germline mutation that's present here. The histology is consistent with the diagnosis, and molecular genetics pointed out the TFEB mutation. He was treated with nephrectomy and careful follow-up, and has not required any chemotherapy thus far because no metastases have shown up after 2 years. The first topic in the Lancet is serotonin receptor signaling. There are 70 separate serotonin receptors. This is a tedious topic. The serotonin receptor that we know the best is 5-HT2B. It's expressed in the central nervous system and also on blood vessels. 5-HT2B receptors, by agonizing them, appetite is inhibited. That's where the fenfluramine disaster came from. And you'll recall that patients ingesting this combination of appetite inhibitors developed a whole series of cardiovascular problems, including valvular scleroses that we also see in people that have carcinoid syndrome. Carcinoid tumors also produce serotonin. That's the connection over 5-HT2B receptors. So those were withdrawn from the market. The topic that we're dealing with today is 5-HT2C receptors, which, according to the authors, are only expressed in the central nervous system. I hope that's the case. And lorcaserin is a drug that activates 5-HT2C receptors, and we hope that that decreases appetite. That's what was tested in this study in obese normoglycemic, obese pre-diabetic, and obese diabetic patients. And one of the hypotheses is, can we keep the pre-diabetics from developing into diabetics? And indeed, that's the case, but there's only a 2% difference here. It's statistically significant, but the number needed to treat here is 50. But there's some hope for that. Body weight decreased by about 3.5 to 4 kilos in the various groups. HbA1c decreased at least transiently in the diabetics, and fasting blood sugar decreased also. These are all favorable responses, but they are not dramatic. And remission of hyperglycemia, prediabetes, and diabetes looks pretty favorable. So lorcaserin might have something to offer people that need to lose weight if they're at risk for developing diabetes, and conceivably could be combined with other treatments. The next topic is the calcitonin gene-related peptide, which is a strong vasodilator, and there's a reason to believe that migraine headaches have at least some vascular basis. And so CGRP receptor have become drug targets, and to inhibit migraine, there's an antibody against CGRP receptors that should block CGRP signaling. And this antibody is called erenumab, and erenumab or placebo were administered to patients with severe migraines that also received a bunch of other things, but the endpoint here was, can we reduce the migraine days per month by at least 50%? By injecting this material every 4 weeks. And that was done in this 12-week study, and this graphic shows here pretty much a 50% response rate. And if we look at the summary, indeed, the monthly number of migraine days was cut in half in the patients that got this antibody against CGRP receptor. Next topic has to do with the food industry. And it's well established that the food industry makes the drug industry look like total beginners. You may need crizotinib if you have non-small cell lung cancer, but that's not very many people. Everybody has to eat 3 meals a day at least. And the dairy industry is one of the greatest lobbyists known. Moo. And just as a short summary here, there are donations to various aspects, at least in the United States, can be followed in the internet. And so they're one of the strongest lobbies that I know of in all countries. Everybody loves cows. That's no different in France and Germany. In India, they're even holy. And so the consumption of milk and dairy products is a big issue to the dairy industry. Now, in the so-called third world, or the developing countries that are developing at their own endogenous rate, evidently, the consumption of dairy products is even less than in acculturated countries, and the dairy industry would like to change that. So the first thing they have to do is get rid of the stigma that milk and cheese could be bad for you and that it might cause more heart disease, because the dairy industry would like us to believe that consuming large amounts of dairy products, it reduces heart disease. So Salam Yusuf and his establishment went after this hypothesis in Southwest Asia, Southeast Asia, in the Middle East, in Africa, in South America, also in Europe and North America, 134,000 people. And indeed, the consumption of dairy products in most of these places was favorable to the dairy industry, and the more milk and cheese and ice cream you ate, the less heart attack and stroke you got. That's what they say. So the risk of stroke was markedly lower with higher consumption of dairy products. So they're delighted. Now, before we all go home and ingest this information on this 136,384 people from 21 countries with 10,567 events, we should at least look at the sponsors. And they were many. Boehringer Ingelheim in Germany, I'm not quite sure what they have to do with cows and cheese. The Saudis, Saudi Arabia, Breslau Medical University, the South African Sugar Association. Well, draw your own conclusions. A patient out of the Lancet was a 29-year-old woman who was referred because of flank pain and severe hypertension. She's also got hypokalemia. She was worked up for secondary hypertension, and indeed, she's got something. We can look at her right kidney. She's got a sharp renal artery stenosis on the right side, and all these dilatory changes here were interpreted as fibromuscular hyperplasia. What was annoying is there was no further information in this case report. I never got a chance to see the kidney on the other side, and what treatment was administered also remains a mystery. The review in the Lancet, the first one is on depression, and this is one of the best reviews on depression that I've encountered. And the severity of depression is shown here: bad mood, anhedonia, loss of interest in sex is what that means, feelings of worthlessness or guilt, suicidal ideation, and then being so depressed that you don't have the energy anymore to commit suicide. That's all reviewed here. And what we also learn is how to evaluate these patients clinically, to gather up their features and the severity and the way that the onset was and whether or not they remit and the patterns, so that we can make some assessment of the major depressive disorders that the patients have. What causes depression? Neurotransmitter hypotheses, the hypothalamus, areas of the brain, neuroplasticity, neurogenesis, inflammatory mechanisms, genes, of course, the environmental milieu, epigenetics, and then management. And there are probably 50 drugs that are available for depression, but other things that can be done: regular exercise, sleep hygiene, also electroconvulsive therapy, on which we have a very good randomized controlled trials, and assessing the goals and then picking the right treatment strategy, the neurotransmitters, excellent images on how this signaling occurs, and the role of blood vessels and neurogenesis. And here's a bunch of serotonin receptors here, as you might have imagined, and the directions that this research is going. Also discussed in the Lancet is hepatitis B virus, and we have a very good vaccination against hepatitis B that we've had for 40 years. But many patients and the people in the world aren't vaccinated against hepatitis B, and migrants that come to Europe probably have not been vaccinated against hepatitis B. How this virus is taken up into cells and how it's replicated is discussed in this review. The different virological markers, surface antigen, the E antigen, an indicator of viral replication, the core and neocapsid antigens that are available, and the patterns in which antibodies to these go up and down compared to liver enzymes. The risk for hepatocellular carcinoma, how the liver should be evaluated in these people with elastography, and how these patients should be classified, and also the treatments that can be given for active hepatitis B infection, and there are effective treatments that can be given. All of that is covered in this excellent review. We close with this interactive case out of the New England Journal. And I love these, although I have some issues with this one. Woman, worst pain in her life. And most women, at least if they have children, have some idea about pain. This headache requires codeine for relief. Physical examination is positive, and that she has superior bitemporal visual field defects, indicating that something is not okay in her optic chiasma. Thunderclap headaches with field cuts. I thought about subarachnoid hemorrhage, and if I were in the emergency room, I'd send her to CT immediately because that can be done within 20 minutes. History is taken. This history indicates that this person is alert and awake. That suggests that this syndrome is not acute. She's able to tell you that her maternal grandmother had diabetes. That's pretty detailed, but I still think she needs to go to CT now. Laboratory values are done. This takes a while to come back. She could have gone to CT in this time. Serum sodium 118, hyponatremia, renal function even better than normal, glucose normal, calcium phosphate normal, serum osmolality low. Okay, this is real hyponatremia. Urine osmolality indicates that antidiuretic hormone is present because her urine is relatively concentrated. She has a urine sodium of 85. Her serum sodium is 118. To determine if she's getting better or worse, we need to know her urine potassium, because then we can add urine sodium and urine potassium, and if it's greater than serum sodium, she's getting worse. If it's less than serum sodium, she's getting better, or at least she'll stay the same. But these Bostonians didn't bother to measure urine potassium. So we're asked, is this SIADH? Certainly. Could cortisol deficiency be responsible? Yes. So those are the answers. Then we're asked to make a therapeutic decision. Sodium chloride tablets are always wrong. Don't give them. Hypertonic saline can be right, and if you want to raise serum sodium by about 3 to 4 millimoles per liter, giving about 100 milliliters of 3% hypertonic saline would achieve that goal. Giving more hypertonic saline than that might be dangerous because we don't want to raise serum sodium too quickly, because then she might get central pontine myelinolysis. Restricting intake of free water is fairly useless, but if we know urine potassium and urine sodium, we can make a decision whether or not she's getting better or worse, because I still believe she needs to go to CT. Should have already been there, because hyponatremia can cause symptoms, but I'm not aware that headache or visual field cuts are caused by hyponatremia. Key points. You can read those on your own. That's all right. What to do next? The authors want us to give hypertonic saline. I want her to go to CT. More key points. More labs are done. These are labs that take 2 weeks to come back. Thyrotropin, free thyroxine, morning cortisol. Had to wait till the next morning to draw that one. Allo, prolactin. Well, all of these things are low except for prolactin, indicating that something's going on at the hypothalamic level. Now, the problems that this patient has are secondary to some sort of problem in release of driving hormones that drive the primary organs, the adrenal gland, the thyroid gland, and ovaries. So this is secondary adrenal insufficiency, secondary hypogonadism, and secondary hypothyroidism. Easy question. Finally, CT. Don't know, not very good. She's got a cystic mass in the sella. Wonder if she didn't bleed into it. This is a Rathke's cleft cyst. This is sort of a congenital kind of lesion, but it suddenly caused symptoms. Wonder if this white stuff is related to that. No, don't know. I'm not good enough at radiology. The MRI scan shows this cystic structure. Didn't help me too much. Finally, diagnosis is made. Here's the anatomy of this area. And indeed, she's then taken to the operating room. A transsphenoidal operation is performed to remove the cystic lesion. We can look at the histology here. This is a Rathke's cleft cyst. In this patient causing secondary adrenal, thyroid, gonadal insufficiency, and hyponatremia. Related to ADH? Sure. That's why her urine osmolality was 565. Now she's better. She gets hormone replacement therapy, all smiles, and she gets to go home. I still think the CT should have been done in the emergency room in the first 20 minutes because perhaps she bled into this Rathke's cleft cyst. Could have had a subarachnoid hemorrhage. Might have needed attention. And don't forget about the fact that if you really want to know what happens, in addition to measuring sodium in the urine, you also have to measure potassium in the urine. Because if the sum of the two are greater than the serum sodium, the patient is getting worse. If the sum of the two are less than the serum sodium, the patient's going to get better, irrespective of what you do. Giving hypertonic saline is okay, but you have to know how much and how fast. And it's particularly indicated in people that have symptomatic hyponatremia. But I don't think headache and visual field cuts are caused by hyponatremia. Thank you very much. Join me next week for another fascinating clinical journal club.